Hey all, so today we are going to discuss about regressive alterations of teeth. So in this video we will discuss about four topics only, that is attrition, abrasion, erosion and abfraction. Rest of the topics we will discuss in the next video, right? So we will start with the very first topic, that is attrition. So as we know that teeth are present in our oral cavity which are in contact with each other. Also the teeth are in contact with the teeth of the opposite arch, right? So it causes wearing away of tooth surface, right? Due to tooth contact, such as in mastication, right? So it is basically a physiological process in which there is wearing away of tooth surface. So the surfaces which are involved in attrition are occlusal, incisal and proximal, right? Here in this picture you can see that a treated tooth are there, right? Or a treated teeth are there, and there is loss of incisal surfaces due to attrition basically. It plays a physiological role, right, in maintaining crown to root ratio, right? So as we have read that attrition is basically a physiological process, but it can be considered pathological, right, when it causes functional, aesthetics and dental sensitivity problems, right? So pathological attrition occurs due to abnormality in occlusion, right? Very important cause. And the second one is chewing pattern, right? Or due to parafunctional habits such as bruxism or clenching, right? Or due to structural defect of teeth such as dentinogenesis imperfecta or amelogenesis imperfecta, right? So now the etiological factors of pathological attrition. It may occur due to abnormal occlusion. Abnormal occlusion can be due to developmental reasons such as crowding of teeth or certain malocclusions, right? And the second one is acquired. Acquired may be due to extraction of teeth, which may increase the occlusal load over the remaining teeth present in the oral cavity and will result in attrition of teeth, right? And the third one is premature contact, such as in edge to edge molar relations, right? The second reason is for pathological attrition is parafunctional habits such as bruxism and clenching of teeth. Bruxism and clenching, right? Third one is occupational reasons. So in certain occupations, workers are exposed to an atmosphere of abrasive dust, right, and cannot avoid it getting into the mouth. So it will result in attrition of teeth. And the last one is the structural defects such as amelogenesis imperfecta, amelogenesis imperfecta, and dentinogenesis imperfecta. Right, so these are the etiological factors of pathological attrition. One more point, attrition is also seen in the individuals who are habitual of eating tobacco, right? Now the clinical features of attrition. So the first one is men exhibit more severe attrition as compared to women, right, due to greater masticatory forces. And it can involve both the dentitions, that is primary as well as secondary, right? Deciduous as well as permanent dentition, both are involved, but the severe form is rarely seen in deciduous dentition, right? The surfaces involved in attrition are incisal, right, occlusal and the proximal surfaces, right? Now the first clinical manifestation of attrition is appearance of small polished facet on the cusp tips, right? Or it may cause slight flattening of the incisal edges, as you can see in this picture, right? So there is slight flattening of the incisal edges. Now the physiological attrition, which starts with wearing away of incisal edges of the incisors first, and after that it involves the cusp of the molars also. So after incisal edges are flattened, the palatal cusp of the maxillary molars and buccal cusp of mandibular molars are also involved, right? Or attreated, you can say. Secondly, it starts at the time of contact or occlusion, right? Thirdly, it results in reduction of both vertical height as well as the horizontal tooth width. So the mesiodistal dimension of the crown is also reduced. Also, the vertical height of the crown is reduced. And the color of the tooth may also alter, right? So extrinsic yellow or brown staining on the tooth can be seen due to exposed dentine, right? Due to wearing away of enamel and the dentine is exposed, so it will give extrinsic yellow or brown staining to the tooth. So the signs of physiological attrition are the cusp height of the tooth is reduced, right? Occlusal inclined plane is basically flattened, right? The dental arch, there would be the shortening of length of the dental arch, right? Due to decrease in the mesiodistal dimension of the teeth, right? So as the mesiodistal dimension of the teeth is reduced, it will cause reduction in the length of the dental arch. Now, due to attrition, when dentine is exposed to the environment, the dentinal tubules are also exposed, right? As we know that exposure of dentinal tubules will cause irritation in the odontoblastic processes of the dentine, right? So, this will cause stimulation of the dentine and will result in the formation of secondary dentine in order to protect the tooth, right, from sensitivity or any irritation, right? Now the pathological attrition in which severe tooth loss is seen, right, due to which dentoalveolar compensation would take place, right, as the cuspal height is reduced, which will result in loss of intercuspation of the teeth, intercuspation, right? So it will lead to flattening of the occlusal surfaces, resulting in reduction of the vertical dimension of occlusion, that is VDO is basically reduced in this condition, right? Surprisingly, VDR, that is vertical dimension of rest, is vertical dimension of rest remains same basically, right? Secondly, there would be increase in freeway space, and thirdly, there may occur forward posturing of the mandible in severe conditions, right? I hope you know what is freeway space. So freeway space is basically the difference between vertical dimension of rest and vertical dimension of occlusion, right? The radiographic features of pathological attrition. So radiographically you can see the shortened crown length, right? Sclerosis of the pulp chamber. So the pulp chamber would be seen as calcified or something, right? The periodontal ligamental space is basically widened, and nextly some loss of alveolar bone can also be seen radiographically, right? Now the management part of attrition. So the first one is habit breaking appliances should be used to for the parafunctional habits such as bruxism and clenching. For that purpose we can use night guards, etc., right? And correction of malocclusion is required, right? So we can undergo orthodontic treatments. Usage of non-abrasive dentrifices is recommended, and management of sensitivity and aesthetics is required in attrition, right? So now we are going to discuss about abrasion. Abrasion is basically wearing away of tooth substance that takes place due to some abnormal mechanical process which is caused via some external agents, external agents, right? So this process is basically pathological in nature because it is caused via some external agents and will lead to wearing away of tooth substance, right? So the causes of abrasion are such as abrasive toothpaste. So abrasive toothpaste is basically a external agent which will cause abrasion, right? So opening of bobby pins will also cause abrasion, right? Habitual pipe smokers, in these people you can see abrasion of the incisors, right? Horizontal tooth brushing technique is basically an abnormal mechanical process which will cause abrasion. Holding nails or pins will cause abrasion, and improper use of dental floss can also cause abrasion, right? So these are all the causative agents or external agents which causes abrasion of teeth, right? So here you can see the clinical pictures of abrasion basically. So this is a bobby pin, you can see. So the person is habitual of opening the bobby pins with teeth. So this will lead to abrasion of incisors, as you can see, right? Now in this picture you can see the toothbrush abrasion, right? Due to horizontal tooth brushing technique. This is also a form of abrasion. And abrasion is also seen in pipe smokers, right? So now we are going to discuss about toothbrush injury. So in toothbrush injury, what happens? Abrasion affects the exposed surfaces of the roots of the teeth, right? And also the facial surface of crown basically, right? So what happens in abrasion? Abrasion is basically associated with gingival recession, right? So due to gingival recession, what happens? The root area or root surface of the tooth is exposed and it will lead to abrasion of that surface also. So it is more commonly seen on the left side of right-handed people and vice versa. So the people who are habitual of using their right hand for toothbrushing will affect their left side of the teeth, right? And the appearance of the lesion is basically it is V-shaped or wedge-shaped, which you can see on the root area at the level of CEJ, which is limited coronally by enamel, right? So as the dentine is exposed, so it will lead to sensitivity, and to protect our tooth, secondary dentine formation will occur, right? So angle formed in the depth of the lesion as well as that of enamel edge is sharp one. So it is basically a V-shaped or wedge-shaped lesion in toothbrush abrasion, right? So lesions are basically more wide, right, than deep, right? So these lesions are basically wider than it is deeper. So dentinal features, as the dentine is exposed, so the exposed dentine is highly polished in nature, right, in toothbrush abrasion. Premolars and cuspids are more commonly affected, right? Now the dental floss or toothpick injury. As we know that abrasion is not only caused by toothbrush injury, it can also be caused by any of the reasons such as dental floss or toothpick or habitual pipe smoking or opening of the bobby pins. So the clinical pictures of abrasion varies a lot, right? So in dental floss or toothpick injury, we can see cervical portions of the proximal surfaces to be affected, right, just above the gingival margin. So the cervical portion of the proximal surfaces of the tooth is basically affected in dental floss or toothpick injury. So the management is modified teeth cleaning habit should be recommended, right? Because there are some abnormal mechanical processes such as horizontal toothbrushing technique, which is a wrong teeth cleaning habit, you can say. So modified teeth cleaning habit is recommended. Removal of the cause such as external agents, toothpick, dental floss, bobby pins, pipe smoking, right? And restoration of the affected tooth structure is done, right? So this is all about the management. So till now we have discussed about attrition, which was caused by tooth to tooth contact. After that we have discussed about abrasion, that was caused by some mechanical process via some external agents. Now we are going to discuss about erosion, which is wearing away of tooth structure or dental hard tissue by a chemical process, right? And it is basically an irreversible loss of dental hard tissue by a chemical process or due to some acids, you can say, that does not involve bacteria. So what happens in erosion? There is dissolution of mineralized tooth structure when it comes in contact with acids. So acids are released intrinsically also, or there may be some extrinsic sources also. So firstly we will discuss about extrinsic sources. So the first one is acidic beverages such as um, carbonated drinks, right, which are having low pH level or acidic pH, right, or sports drink, or you can say fruit juices also, right, fruit juices. After that, foods such as citrus fruits, these all are having low pH level, or they may cause contact of acid with the tooth surface, will cause erosion only. Medications such as vitamin C supplements and HCl hydrochloric acid supplements also. So both of these are considered or are basically acidic in nature, will cause erosion, right? And lastly, the occupational and recreational errors such as occupational wine tasters. So these are more prone to erosion of teeth, right? So erosion is reported in swimmers also. So these are the occupational and recreational errors, you can say. Now the intrinsic causes of erosion. So the first one is GERD, that is gastroesophageal reflux disease, right, in which all the acids which are produced in our stomach basically are regurgitated into our esophagus and the oral cavity. So the acids which are having a pH level of less than 1 or equal to 1 comes in contact with the teeth basically and will cause erosion of teeth due to acidity, you can say, or due to GERD, right? Now the second intrinsic cause of erosion is chronic excessive vomiting, right? So it is seen in an individual with eating disorders such as anorexia nervosa or bulimia, in which the individual is very much conscious about his or her body weight and they starve themselves till death maybe, right? So due to which whatever they try to eat or whatever they eat, they try to vomit it out. So it leads to chronic excessive vomiting basically. So erosion that is caused by vomiting will cause palatal surfaces of maxillary teeth to be affected, right? But erosion that is caused due to extrinsic factors or such as carbonated drinks or acidic drinks will affect the labial aspect of the tooth structure, right? Now the management part of erosion. So avoid acidic beverages or foods, right? Secondly, treat GERD, that is gastroesophageal reflux disease. Thirdly, for salivary hypofunction, as we know that whenever the pH level of our oral cavity is decreased, our saliva acts as buffer. But in some individual, what happens, salivary hypofunction is there, which will cause or which will increase the rate of erosion of our teeth. In those cases, or in those for those individual, we are supposed to give them sugarless chewing gum or oral pilocarpine, which will increase the salivary flow rate or saliva secretion basically, right? So for salivary hypofunction, we give them sugarless chewing gum or oral pilocarpine, right? Eating disorder treatment should be done. Topical fluorides and occlusal splints can be given, right? Now we are going to discuss about Abfraction, right? And the term Abfraction was coined by Grippo in 1991. So this term is basically a hypothetical term because its etiology is not yet supported, right? So Abfraction by definition is pathological loss of tooth enamel and dentine caused by biomechanical loading forces, or you can say abnormal occlusal forces, right? Or the static forces that are generated while chewing, swallowing, clenching of teeth, right? So these are the reasons for abfraction or loss of tooth structure, or basically tooth enamel and dentine, right? Due to these forces. In abfraction, buccal gingival third of clinical crown is affected, right? So abfraction is seen on the buccal surfaces, right? So as we know that abfraction occurs due to biomechanical loading forces. So these forces will generate stress over the crown, right? And that's why this abfraction is also known as stress region, right? Now the mechanism of abfraction. So firstly, abnormal occlusal forces will act on the tooth, right, which will result in tooth flexure. This will result in tensile and compressive stress to be generated over the crown, that is gingival third of the crown, and will lead to micro fractures. So these micro fractures over a period of time will take up a notch shaped appearance, right? So here in this picture you can see that when occlusal forces are acting normally, right, then there is no stress that is generated on the opposing tooth, right? So no microflexion at cervical region will be seen, right? But now when eccentric forces or abnormal occlusal forces are acting on the opposing tooth, this will create tensile stress over the buccal surface of or buccal gingival third of the crown, right, which will lead to microfracture in enamel portion of the clinical crown basically, and with time it will take up wedge shaped appearance, or wedge shaped notch at cervical region will be seen, right? So this is a typical feature of abfraction in which we will see wedge shaped notch, right, at gingival third of the clinical crown basically. So other causative factors of abfraction are: number one, occlusal restoration. So it is suggested that occlusal restoration may lead to weakening of the tooth structure. So the tooth will lose its ability to resist the stresses of occlusion basically. So it will lead to abfraction. Also, factors such as erosion and abrasion may play a significant role in tooth tissue loss. As we know that tooth wear is having multifactorial etiology. So you should remember that whenever tooth abrasion is there or tooth erosion is there, abfraction may also occur subsequently, right? Now, due to abfraction, it affects buccal or labial cervical areas of the clinical crown, right? It commonly affects single tooth or the tooth structure which are having greater occlusal loads, right? Or with excursive interferences or eccentric occlusal loads. Now the appearance of abfraction lesion, you can say. So these lesions are basically very deep and narrow V-shaped notch which are present at the cervical third of the clinical crown. It is basically wedge shaped with sharp line angles, right? So abfraction may also involve occlusal surfaces also. So occlusal abfraction may present as circular invaginations on the occlusal surfaces basically, right? Now the breakdown of the tooth structure basically depends upon the forces that are applied, right? So it is dependent upon the magnitude, duration, direction, frequency, location of the forces, right? So these forces will generate stress on the cervical third of the clinical crown, right? So basically the breakdown of the tooth structure is dependent upon the forces or the abnormal occlusal forces, right? So the clinical picture of abfraction may vary from a small lesion to a very deep wedge-shaped lesion at the cervical area of the clinical crown basically, right? Now the management part. So patient is advised to wear bite guards in order to protect the tooth structure from abnormal occlusal forces, right? And deep areas of notching can be restored, right? So let's recapitulate abrasion and abfraction, right? So abrasion is caused by mechanical forces which are generated via external agents, whereas abfraction is caused by eccentric occlusal forces, right? So abrasion lesion is seen or located at cervical areas of the crown and exposed root surfaces. Also, abrasion is associated with gingival recession, right? Moreover, the exposed dentine in abrasion is highly polished, right? Whereas in abfraction, buccal, labial, cervical areas of clinical crown are affected, right? In abrasion, lesions are more wide than deep, whereas in abfraction you can see a notch, right? Deep, narrow, V-shaped notch can be seen in abfraction. Abrasion involves premolars and cuspids, right? More commonly affected, and abfraction affects single teeth or single tooth structure with eccentric occlusal loads. So this was all about attrition, abrasion, erosion and abfraction. Thank you for watching.